Moving on to the next session of ECO today. Happy to see you all again. And Rajalakshmi is not there today, so we'll we'll all will go together without Rajalakshmi today. So today's session on psychosocial issues in palliative care. Uh, uh, and I'm happy to introduce my colleague and my friend Smriti. She's the consultant psychologist in Pallium, and she's the director of programs and projects in Pallium. But I would prefer to introduce her as the psychologist because I love that part much more than the other role, and she has done a wonderful job for us. Welcome, Smriti, to the session, and happy to see you.
Thanks, Ree. Thank you, and thank you for that very sweet introduction. Happy to be here and happy to have psychosocial aspects of care included in a doctor's series. So I'm not going to delay much longer because my technical issues I had, and then we've delayed already. So to start, to dive right in, is my screen visible to everybody?
Yes, ma'am. Yes, yes.
Great. So this is actually something that we have been working on, and it's an evolving process for us. So I have to acknowledge the fact that a large part of this presentation was put together by someone who worked with us earlier, one of my ex-colleagues, Shara, in the UK. But this has been a joint effort by the entire psychosocial team at Pallium India. And so today we're going to talk about the fact that psychosocial aspects of care, of course, are a very important part of the multidisciplinary process. And while we all have our own areas of expertise, it's truly when the multidisciplinary team comes together that a proper plan of care can really be devised. And we all agree that palliative care looks at care of the whole person. So I'm going to introduce you to the psychosocial aspects. I'm sure most of you are quite familiar with what I'm going to be talking about. I'm just going to try and put it in a more systematic framework for you to follow. Of course, everybody knows this definition, and so I'm not going to take up too much time here, but I just want to draw your attention to the words that are highlighted in red. So I'm just going to read through it once. Palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Of course, we have expanded that definition now to also include illness-related suffering, not just life-threatening, life-limiting as well. So that is something that needs to be updated here, of course. So why psychosocial care, and why is it? Why do we feel that in this series? Why is it important that medical clinicians are being made to sit through a session on this? The simple reason is that when somebody has a diagnosis of a life-limiting or life-threatening illness, or has the awareness of approaching death, there's a whole lot of unique stressors and challenges that emerge. Of course, they are grappling with their physical distress and the physicality of the disease itself. But of course, there are whole other challenges that come. And so we're going to be looking into that as we go along. And understanding the factors related to a patient's quality of life is essential in providing appropriate care. And let's remember here that quality of life is not only determined by physical comfort. It has a huge component of psychosocial, emotional, spiritual, financial, all of those things as well. I'm not sure how many people in the audience today are completely familiar with the idea of total pain. But this is something that we were taught very early, which is when a patient reports his or her subjective pain on the pain scale, which is something that I'm sure everybody knows, it is important to remember that the physical pain reported by a patient is compounded by his or her current life circumstances. So what does that sentence really mean? So I'm going to ask you to imagine a situation where, it's a normal day, you wake up, but on this day you wake up with a headache. And if I were to ask you, how bad is the headache, you would score it on your pain scale. So if you were to have a headache and on that day you're allowed to stay back home, work from home, you have somebody to look after you, you have you're comfortable, and everything is going well. And if I ask you to score that pain, you probably tell me that it's a 4 or a 5. But if you had that same headache and you had 2 deadlines to meet that day, on your way to work, your vehicle breaks down, you get into work, your boss yells at you, you get a call from home saying something else is not working right there, you have an argument with somebody at home, I would imagine that that same headache is going to score a little bit higher on the pain scale that day, because it's a terrible day, isn't it? It just sounds like such a terrible day. But the experience of pain is really affected and influenced by what is happening to a person and what's happening to a person. And the example that I just gave you is a very trivial one. And if you were to take that example and multiply it by 1,000, and look at it from the context of somebody who's in advanced stages of cancer, has a lot of uncontrolled pain, has financial difficulties because of it, because of the treatment. Children have had to drop out of school. Future plans have gone completely out of control. Those are the kind of elements I'm talking about when I talk about total pain. And that is something that is intrinsic to the work that we do. So as a clinician, my responsibility, coming from a non-medical background, is to assess the contributive factors leading to total pain. Now, just like you as physicians would assess, various parameters within the body, there are also various other factors that the rest of the multidisciplinary team is also called to assess. And I think rather than a multidisciplinary approach, it's an interdisciplinary approach where all of us have to be aware of what the other team member brings to the table, because ultimately we all have to work together to form that plan of care. So illness-related suffering is much more than just physical distress. That is something I've already mentioned. And these are some of the components that make up total pain. There's a physical component, there's a psychological component, socio-economic, which includes financial stresses, and of course a spiritual component. So we're going to be talking about all of these things, and together all of them contribute to the person's experience of pain and distress and suffering. So to illustrate this point, I'm just going to take you quickly through one case. This is Mrs. D, who was 27 years old and had been diagnosed with cancer of the rectum in 2014. She had chemotherapy and radiation followed by colostomy. She was referred for pain management. And at the time of registration, she presented with severe pain, infection, and a foul smell from the colostomy site. She looked very anxious and scared and had no idea whatsoever about palliative care. And from the medical records and present disease progression, the team had the impression of a very bad prognosis. She is married and her husband is 35 years old. He's a daily wage worker and her child is 6 years old and going to school. So this is just a general background and introduction to Mrs. D. Important areas to be assessed from the point of view of total pain. The aim of the assessment is to identify problem areas which result from the illness and may influence the well-being of the patient as well as the family. So the family is as much a part of the unit of care as the patient is, because there is an interplay of dynamics constantly, and no man is an island. So it's important to know what is going on within the family system as well, and not just with the individual patient. And assessment involves collecting information, of course, identifying and honoring strengths, resources, as well as needs. And assessment and the gathering of information is an ongoing process. So just like in medical care, you would constantly monitor and evaluate the progress and progression of the disease and various other statistics. Similarly, for us, we would need to do the same in terms of recognizing it as an evolving scenario, and then going back to keep checking whether the interventions are working, what is not working. And of course, documentation of this is absolutely vital. So the psychosocial needs of the patients and the family or caregivers often change over the course of the illness. So as they hit different milestones in the disease or illness trajectory, of course, their needs also change. And so one of the first things, of course, we would go into is drawing out a genogram. Now, I'm not going to spend too much time on this because I know all of you are familiar with what a genogram looks like. This is something that we really insist on being a detailed exercise at Pallium, because there's a tendency for people to just draw the immediate nuclear family unit. But drawing out the extended family is just as important, even if they don't live together. Now, why is this important? Because dynamics are influenced not just by who lives together, but what roles they carry out. So suppose there's a caregiver who's a woman who comes to us with her spouse or her son or whoever, and she's the primary caregiver. We would talk to her about the needs of the patient and the family, but asking her to make decisions may not be the most ideal in this situation, because the decision maker could very well be her brother who works somewhere abroad and sends money back to support the family. He is the decision maker because he's the financial controller. And while I can explain all the interventions that we could use on this family, ultimately the decision would lie with that person. Now, I need to understand that she is not the decision maker for various reasons. In our psychosocial training sessions, we talk about gender equity in healthcare and things like that. So it's important for us to know how much of a voice that woman has in that family. And if there is an outside influence, then we need to know who that influence is even within the family. So drawing out the extended family is very, very important. Understanding hostilities, understanding relationship dynamics, and who lives with whom. So the circle is very important. It tells us who is living under the same roof and who is not, right? So sorry, this is a bit of a shaky image, but I would even encourage people to go a step further and draw out the relationships that people share. And this is basically how you would show that. And if you look at it, there are so many different kinds of relationships that exist within a family. There's, of course, the supportive, loving relationship. There's harmony. There's estranged. There's violence. And all of us, I mean, in the human spectrum of emotion, we know that nothing is as simple as it seems on the outside, right? There could be an abusive relationship in the family, which affects how the illness is managed. There could be neglect in the family. There could be hostilities within the family. And by just drawing a genogram that doesn't tell us all these things would be a disservice. And also, I think we would end up, more dangerously, we would end up creating inappropriate plans of care, expecting people in the family to carry out certain tasks when their relationships actually wouldn't allow for it. So these are things that you can get online, and I would encourage people to create genograms, come up with these legends that are most appropriate in your setting, and start utilizing them, because it also saves us writing pages and pages and pages of notes when a simple diagram can tell anybody on the team what to watch out for. Now, if I were to have an important decision made, I need to make sure that I'm not entrusting that decision to a person who is hostile to the patient within the family. And it is a known fact that family dynamics that existed before a crisis, like for example, in our case, it would be an illness, those dynamics get enhanced after the crisis occur. So if a family was cohesive before the illness struck, they had open lines of communication, people were approachable to one another, it's quite likely that that family is going to cope better than a family that already had existing conflicts within it. So it's really, really important for us to know who is talking to who is afraid of whom, who doesn't talk to whom, all of those things. And by doing that, we would then be making more appropriate plans of care, like I said. The other less commonly known assessment technique is an eco map. And this, just like a genogram tells us what is going on, the structure and dynamics within a family, the eco map tells us what the family's relationship is with the larger society. So if you look at these circles, so this is the family right here in the middle, but the school where the child goes to, the church or any other religious establishment or faith-based establishment that the family might be associated with, the physician. I would include the palliative care team that we represent also in this in one of these circles. Social services, non-health related community services, utility services, friends, extended family, And this is an American example, so county health department and so on. So this tells us what relationships people have with all these pretty vital, um, you know, groups that exist outside of the family. In our culture, I would also include neighbors and people that we interact with on a daily basis. So that is like a general introduction to what eco maps are, but you can go into a more detailed eco map where, if you see this, this is the family in the middle, this is the husband and the wife, and these are the children. You can actually, with each of these groups, you can also determine what relationship each of these groups have with each member of the family. Now, if you look at the legend, a straight line is a positive relationship, a dotted line is a tenuous, a strained relationship. This is a stressful relationship. Now, for some reason, and the arrows tell you which way the energy flows. So for some reason, the church and Adam don't get along, right? Adam and where he works, they have a equally mutually positive relationship. So the arrows go both ways, and it's a straight line. So it says it's a smooth relationship. Um, Adam's friends don't like his wife. So that's what it tells us. Small groups. So here it's a very positive relationship with the younger son. So obviously the son has a lot of support here. The importance of an eco map is that it tells us where the family can expect support outside of the immediate family. It tells us where we can mobilize resources. If, say, for example, in our case, there's an elderly couple living alone and they don't have children to help them go to the healthcare facility and so on. If I were to draw out an eco map and I find that one of their neighbors has a very good relationship with them, or the old man probably had a very good relationship with the people he worked with, I will then dip into that resource pool and try and mobilize someone there to maybe go across and meet them once a week, get medication across to them. If one of them has a vehicle, I'd probably ask them to, can you take them across? So the eco map really tells us all that. It also tells me who else to watch out for in the family. Very often we miss out people who are not the patient. And very, very often that would be a child. Children become invisible patients in a family because they're neglected. The focus is on the sick person. And if the person who is sick is a child themselves, I would look out for the sibling, because the child who is sick gets a lot of the attention, all of the attention, and the child who is well is expected to adapt and be okay, and they might develop behavioral problems. Now, if I'm talking to this child's school and I find out that there are behavioral issues showing up there, that's telling me something about how this child is handling this illness. So eco maps also help us strengthen support systems to the invisible patients in the family. Very often, 80% of the time, women across globe, caregivers across the world are women. Women are expected to have that nurturing role. In our culture, sometimes it's we've had several cases where it's been an arranged marriage. She's just come into the family, and an in-law is sick, and the husband goes to a different city to work, and she has to be at home looking after a very sick in-law who she really doesn't know that well. And because she's a caregiver, she has no outside interaction, she's isolated further. So what could I do to make her feel a little bit more supported? So eco maps really come in handy there, and in addressing total pain issues, these are very, very, very effective. And we also have stuff like if there are repairs to be done, if there's renovations to the home to be done, if we find that there's a supportive panchayat there, we would ask them also to pitch in. So I would definitely recommend including eco maps in people's practice. While assessing psychosocial and spiritual suffering, it's not just, people might think that non-medical clinicians, counselors, psychologists, what do we go and do? What do we do with these people? And it's just about therapeutic, cathartic venting. It's not. It's very, very far from that. Just like medicine, there is an art and science to the way we do our assessments, and the observations are very purposeful. There are goals that are set for every session that is had, and the conversations themselves are not meandering and rambling. Very specific questions are asked. If I were talking to a child who I would have to be very careful about the language that I use with the child, what developmental stage the child is at. A child who is 8 years old will understand information very differently from a 14-year-old. So those are things that I need to be sensitive to. And that same child might come back to me 2 years later and ask me questions which I thought that I'd already told him, answered him when he was 9 years old. But now that he's 11, he needs to understand it differently because his cognitive development itself is different. So, things like that, and ensuring that I speak to more than one person in the family so that information is not misunderstood or lost in a crisis situation, things like that. So these are things that we take into consideration and we're very aware of when we have these conversations. And of course, non-verbal cues are really, really important. So I would need to understand what the anxiety is about. Things like making a differentiation between grief and depression. We're very, very quick to diagnose depression in people who are sick, when the fact could very well be that it's just natural grief that they're feeling. So maybe antidepressants are not the answer, but a lot of more in-depth understanding of their grief and anxiety. Okay, so it's very, very purposeful. It's not open-ended and we just let the conversation go where it takes us. There have to be specific goals that are laid down, and some of the possible and most common psychological outcomes of illness are the following. So there's feelings of shock, uncertainty, hopelessness, despair, depending on which part of the illness trajectory the family is at. And there's a line on top that says, psychosocial and spiritual suffering is real, but can be difficult to read and treat. We don't have the ability to calibrate it on a thermometer or a scan. You can't measure somebody's grief on a scale like that, really. There are no, there are no markers telling us when something is too much or too little. There's a lot of discernment that comes in to how we proceed in psychosocial assessment, and how we measure it also may differ from person to person depending on the training that I have or the kind of teamwork that I'm used to. So coming back to the list, of course, there are feelings of shock, uncertainty, hopelessness, and despair. And there's a loss of control when a disease strikes a family. And that loss of control, loss of knowing where this is going, all of that can really strip a person of their autonomy. There is anticipatory grief, which basically means grief for something that has not yet happened, but we all know is going to happen. If we know that somebody has an advanced illness, the fact that the person is going to lose mobility, they're going to lose bodily functioning, they might be able to lose, they might lose the ability to care for themselves. They lose their jobs, they lose a role that they play within the family. If I'm a mother and I get sick and I'm no longer able to perform my role as a mother, that's a loss as well. So anticipatory grief is a series of losses that we incur over a disease spectrum, and anticipatory grief is the grief that we feel for things that we're going to lose. And that is a very, very real thing. And this is something that often gets misdiagnosed as depression. So I would ask you to be quite careful there. Poor insight on diagnosis and prognosis leads to confusion and further anxiety and uncertainty, because the disease has not been explained properly enough, because the options have not been explained well enough. That causes a lot of anxiety. And not knowing something is bad, because then our imagination sort of fills in the gaps. But this is not to say that there are people who probably don't want to know, and they're quite happy to not have the information. So the poor insight and diagnosis and prognosis that I'm talking about here is what has been conveyed or not conveyed by the healthcare system to them. Anxiety about death and the death process. This is an important distinction again to make. We all automatically assume that people are scared of death. One of the biggest reasons we're given for collusion is, please don't tell her, you'll take away their hope. She's scared of dying. We don't want her to think that. But in our practice, time and time again, we find that more than death itself, if we have the courage to ask them this question, we find that people are more afraid of the process of dying. Will there be suffering? Will I be in pain? Am I going to be breathless? Am I going to lose my my dignity? Am I going to be blabbering nonsense? And I don't want, to be humiliated like that. Will I lose bowel control? I don't want my daughter to come and clean me up. So those kinds of things. And the process is the terrifying part in all of this. Now, once we get to that place where we've asked that question, and they, in their mind, also it clarifies, yeah, hey, maybe I'm not so afraid of death, but I'm afraid of how I'm going to die. Then we, as a multidisciplinary team, have the ability to assure them where we can, that we will not abandon them, that, if pain can be controlled, this is what we can do if you start feeling breathless. If you're afraid of excessive nausea, there are ways to control that. So, then it sort of demystifies the whole thing, and the anxiety comes down tremendously. So making the distinction between anxiety about death and anxiety about the death process is a very, very important aspect. And here's where doctors can really do wonderful work, because you understand the science of controlling distressing symptoms. And these are some of the questions that are best answered by a doctor. So as a psychosocial clinician, I might elicit these questions and answers, but this is something that I would encourage the entire multidisciplinary team to hone this skill. Suicide, thoughts of suicide or wanting to hasten death. This is a statistic we have in India. 1 in 5 suicides in India are committed by people who are living with a chronic illness or a life-limiting condition. There are a couple of reasons for that. One is we have very poor symptom control in our country still. And, the focus is on diagnosing something and then curing it and treating it. And if you can't do anything beyond that, people are just sent home. And then they feel like they're a burden on the family. Or the opposite could happen, where they're put into an ICU and it's escalated, treatment modalities are escalated, and financially it ruins the family, and then the person thinks, my God, my family is going into financial ruin because of me. A couple of years ago, there was a case where two parents, where a couple, they moved a court in Andhra Pradesh to seek euthanasia for their son because they couldn't bear to see him in that much pain. And eventually, by the time different palliative care teams tracked that family down, he was already in a hospital in Bangalore with no pain control and bleeding from several orifices, and he'd had a terrible death. But another tragic outcome in another family was that a family killed their son and then committed suicide because they couldn't bear the child's suffering. So suicide is something that suicide risk is something we have to watch out for, because still they come to the palliative care sphere where the whole person is looked at and cared for. Sometimes the fear and the feeling of being a burden is so high that the suicide, the thought of suicide is something that has definitely crossed a lot of patients' minds. So what we then do is we do a suicide risk assessment, and then we do the interventions. And there are various ways to do it. I'm not going to get into here because it's quite, it takes a fair amount of, I think, time and skill to go through that whole process. And poor coping with the illness, of course, again, for various reasons. It could be because of lack of social support. It could be because of own, personal coping strategies that have been used right through their lives. If a person has been a easily stressed, anxious person, then a disease like cancer or something can really, really, send them into an anxious spiral. And also, like I said, the dynamics within the family determine how well or how badly the family copes. And very, very often, psychosocial and spiritual suffering can manifest as physical complaints. Everything is connected. Our minds and our bodies and our spirit, everything is connected to one another. So pain and suffering in one part does manifest in other parts of us as people, right? So I mean, even if you look at literature, or if you look at poetry or whatever, whenever suffering is talked about, there is also a physical component to it. Like emotional, spiritual suffering does have a physical component, and vice versa. Speaking of spiritual assessment, this is a really incredible tool that we have adapted to our setting. The spiritual assessment tool, and you'll be able to find this quite easily. It's also in the Oxford textbook. And here I want to clarify that I don't mean spirituality only from the point of view of religion. Religion, of course, can be a very important part of somebody's spiritual experience. But here, what we mean when we say spirituality is a sense of meaning and connectedness in life. And people might find their spirituality in different things. It could be their faith, it could be a sense of service to the community, it could be their relationship with the natural world, it could be their relationship with music and art and their children, it could be relationships. So spirituality can be found across different dimensions and domains. And this tool very clearly tells us 4 areas of assessment: connection, meaning and joy, strength and comfort, hope and concerns. So these are the elements that make up somebody's sense of spirituality and meaning. Excuse me. So for each of these domains, there are very easy and wonderful questions that have been put down. So if I were to want to explore somebody's level of connection, these are the questions I would ask. Who are the persons or communities you look to for support? What role do they have in your care? Do you have the image of a power greater than yourself? Has your life situation now affected your feelings about yourself, your faith, or your relationships? So is there a loss of connection? Quite often we find people who, on their deathbed, either their faith is strengthened, or sometimes it is questioned. I've led a good life. I've been a good human being. Why is God doing this to me? So there are all these questions that emerge when people are, especially towards the end of their lives. If I were to explore meaning and joy, I would ask them questions like, what has been most important in your life? What are you most thankful for? What makes or has made you happy? What do you feel the proudest of in your life? Strength and comfort questions would include, is there anything that is comforting to you now? What helped you get through difficult times in the past? Who or what is your source of strength now? And if I were to explore hope and concerns, I would ask them, is there anything that you hope for? Is there anything that feels unfinished? Now, I'd like to also draw your attention to the fact that these are not just questions that help us understand these 4 aspects. When somebody is sick, it is very, very easy for them to focus only on the negative. Everything that they have lost, everything they're about to lose, all the terrible tragedies that are going on around them. If you look at these questions also serve to remind people of what the good things in their life have been. It tells us where they draw their strength from, and that allows us to, then mobilize that strength, or maybe remind them that, yes, there are these people. What have you been most proud of? It's almost like a legacy question. When I ask somebody, what are you most proud of in your life, and you tell me what you have achieved that you're proud of, it's nice to be seen. It's nice for somebody to recognize that that is something that has brought you a sense of achievement. So it is a very reframing, and this entire series of questions here can pivot the person back onto a more sort of thankful plane. Not all of these questions can be, this is not a checklist. So I wouldn't recommend that you have this checklist and go through these questions. I would encourage you to work these questions into a conversation. It takes a certain amount of rapport building till somebody's willing to answer these questions. If I just walk up to some patient I met 3 minutes ago and ask them, any of these questions, they're probably going to give me some sort of a polite answer, if at all. But I don't think I'm going to get an in-depth, authentic answer. So rapport building is really, really important. And I know that this last section, hope and concerns, is a tricky one. Very often, we don't want to know what they're hoping for because we think what they're hoping for is going to be impossible. I know a lot of palliative care professionals, myself included, I don't want to give them false hope. That is something I've heard from the medical fraternity a lot, from the healthcare fraternity a lot. Now, what is false hope? Nobody believes that they're immortal, actually, if you think about it. So nobody thinks that, they're going to live forever. But there is this fear that if you acknowledge that, there's a time limit now that is set, somehow it's going to destroy that person. That may happen in some cases. But you can reframe hope to small achievable things, right? What do you hope to do with the time that you have? And are there any conversations that you'd like to have? So that's another area, hope, realistic hope versus unrealistic hope. That's something that is again a very tenuous area, but you will not be depriving somebody of hope if you actually start talking about the realities of the illness, if it's done tactfully and sensitively. So that is just something that I wanted to put out there. Now, when we come back to Mrs. D's story, the lady with the colostomy and the 6-year-old child and all of that, uh, once we've done the genogram, the eco map, the spiritual assessment, and their financial assessment and all of that, this is what we found. Under the physical domain, she was unclear about her prognosis. She didn't really know what was going on. There was a lot of discomfort due to the colostomy bag. She was constantly fatigued and she couldn't sleep. There was a lack of sleep. On the psychosocial front, her relationship with her husband and his family were starting to get strained. The colostomy bag made her feel humiliated. She was hesitant to go out and interact with people with her colostomy bag, and that was isolating her further. She used to be a social person, but now she felt ashamed and embarrassed, so she was more and more confined to herself. And a lot of anxiety about the future, and a general sense of fear. She was just afraid, and she didn't know what she was afraid of, but she was afraid. And on the socioeconomic front, we found that because the husband was taking care of her and had to be at home and look after her many days of the week, uh, he was losing his wages because he was a daily wage worker. There was worry about the educational expenses of the child, and she lives in a very rural area, so access to the RCC or the hospital was very tough. So these were some of the most dominant concerns that they had in that socioeconomic sphere. And as far as spirituality was concerned, she was in extreme spiritual distress. She couldn't understand why she had to suffer so much in spite of being a strong believer of God. And there was a loss of connection with family and friends and community because of these reasons and these reasons and these reasons, and loss of interest in pleasurable activities. So that could very well be a sign that she was also depressed. So these were the things that emerged, and that was contributing to her total pain. So of course, interventions were taken, were brought into the picture, and we tried to address a lot of the concerns that she had. So we stepped in with the educational support of the child. So that was one thing that was taken care of. We had several conversations about what the prognosis meant. And once she had that information and she was able to process it, then this generalized fear and anxiety also diminished, because a lot of that generalized fear and anxiety was coming from the fact that she did not have enough information. Lack of sleep was partly due to her anxiety, but was also partly due to the medication that she had been given. So that was sort of course corrected. Strained relationship with the husband and his family for various reasons. So many family sessions were had to understand what the factors were that contributed to the strain. The fact that, her colostomy bag made her feel humiliated, and it had affected her intimate life with her husband as well. And that was causing further strain to both of them. And so to sort of talk about it, to talk about, management of the colostomy bag, irrigation of it, so on and so forth, that was also done. And on a spiritual level, uh, I think we brought in somebody who she could speak with from her religious faith point of view. But this loss of connection with her family, friends, and community got better once we had these conversations. And also once the child went back to school and all of that. And automatically there was a increase in interest in pleasurable activities after a lot of these factors of suffering were attended to and addressed. Very quickly, I'm just going to touch upon something that I think is extremely important, dignity. And the sentence here reads, the inability to acknowledge personhood, the insensitivity of not acknowledging personhood can be psychologically devastating. So what is personhood and what is dignity? So this book, Dignity Therapy, Final Words for Final Days, is by a doctor called Dr. Harvey Max Chochinov, who's Canadian. He still conducts these training sessions. And in my opinion, it's one of the most seminal books I've read. It draws on 20 years worth of experience. It is now an evidence-based, well-researched subject, and dignity therapy has now emerged as one of the front runners in palliative care, in providing psychosocial care. Now, if you take a moment to think about what dignity really is, dignity is like the word love. It's like the word joy. We all know that it's important. We all know that it's positive. But if I were to ask you to put it in a box and define it, it would mean different things to different people. So dignity is a very sort of variable entity like that, depending on who you're talking to. But it is vital nonetheless. So dignity therapy talks about dignity conserving care. Every human being has a sense of dignity. It is tied to various things. My dignity could be tied to my contribution to society. My dignity could be tied to the fact that I'm independent and I like to do things for myself. And there are things that there are certain practices that we can bring into our own teams that will conserve whatever dignity they have, or we can do dignity building exercises with them, right? So that is a book that I'm going to recommend to everybody to read. That will give you a sense of what I'm talking about. But we also need to remember things like, if I talk to a patient, and this happens very often, when somebody falls sick in a family, the minute the diagnosis comes in, the whole family starts treating the person like a patient, to the extent where if the person wants to pick up a glass of water by themselves, the family won't let them do it. No, 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 I'll do it for you. So where a person had till the previous day been a fully functioning, autonomous member of that family is suddenly treated like a patient by the family itself, is already diminished. The person's personhood is diminished. Now, some people may not mind that, so many people are looking after them, but to some people, it's an assault to their sense of dignity that they're not being allowed to be part of decision-making processes. They're being talked to as though they're children, things like that. So these are things to be mindful of. And attitude, behavior, compassion, and dialogue, these are the ABCD of dignity conserving care. The attitude that with which we present to somebody, how we address them. I find that there's a tendency in the healthcare system to call the primary caregiver or whoever the person accompanying the patient is the bystander, which I find deeply offensive personally, because that is the person who is actually on the front lines of this battle, so to speak, and they're there running around doing the paperwork, looking after the patient. And bystander is such a dismissive word. It means someone who's just standing by. And on so many occasions, we have found that when a family comes to us and we ask the caregiver what their name is, they're shocked because nobody has ever asked them for their name. So that in itself, that attitude of, acknowledging that this is also a human being, immediately restores their dignity to them. So that is attitude. Our behavior, the way we speak with them. And I'm sure you have a class on communications and stuff. So, our non-verbal cues, how we face them, whether we're standing, whether we're sitting, whether we take a few minutes to, be kind to them. So behavior is also very important. Compassion is demonstrated through our behavior and our attitude. And dialogue, of course, communication, and making sure it's a two-way communication. It's not, the healthcare professional talking down to a patient. It is actually a dialogue between equals. And there's this really beautiful quote by Pema Chodron, who's a Buddhist monk. She said, compassion is not a relationship between the healer and the wounded. It is a relationship between equals. And I think that is something that we all need to remember. People experiencing a loss of dignity have significantly higher rates of depression and feelings of hopelessness. And this is something that has emerged after years and years of study. One moment, please. Sorry. So the fact that loss of dignity is directly associated with depression and loneliness, depression, anxiety, and feeling of hopelessness. This is a validated sort of statement. Like it is something that we see right across the board. So it is very important to not forget that, acknowledging what brings dignity to somebody is really, really vital to the plan of care. This is what is the dignity question. We call it the dignity question. This is the most central question that you can ask somebody. What do I need to know about you to help you better? It's a very simple question, but it's also a very profound one. And you might find that the answers will surprise you. Someone might tell you that, well, my father abandoned my mother when I was 6 years old, and he abandoned the family. Now, how does that bit of information help me help him? What it tells me is that here is somebody who's been abandoned once and it has had a detrimental effect on his life, and he's probably been afraid of abandonment ever since. So, in a way, he's afraid that he's going to be abandoned at this time of his life as well. So, what I can do in response is to assure him through my attitude, through my behavior, and through my communication that we, as a palliative care team, will not abandon him. And we will walk with him for the rest of the journey, whatever he has. So, that's one possible answer to this question. Someone else might tell you that they like to eat ice cream. How do you associate dignity with somebody who likes to eat ice cream? I suppose it tells me that this person likes to take pleasure in the small things. Of course, the answer to this question may also change every time you ask it, but it really gives us an insight into who we are really dealing with in terms of, person to person. Some helpful questions that you could sort of adapt to your own context are: how has your dignity been affected by your illness? Do you believe that dignity is something that can be given or taken away by others? There might be people who say, no, my dignity is my dignity. I have it. Irrespective of what anyone else says or does, it's something that only I have control over. But somebody else might say, yeah, I felt that my dignity was really shattered when such and such thing happened. So obviously they feel that it's something that is controlled by the outside, by the people and by society around him or whatever. Have you felt that your dignity was taken away from you, and how? The answer might be something like, I was lying in the hospital bed, and then the doctor came and with all the students, with all the medical students, and they didn't even ask me for my name. They referred to me by my file number or my case number. And then without even asking me, he took off the sheet and changed the catheter in front of so many people. That really affected my dignity. So those are some of the answers that you can get. And if you think about it, it is an assault on somebody's dignity to do that without their permission. And how can we support your sense of dignity? What can we do to make sure that your dignity is not, undermined? We once had a patient who said, I've been a teacher all my life and I've been used to, being addressed in a particular way and all of that. And it's fine. You can call me by my first name, but, I don't like it when I'm referred to as a bystander. So these are all things that can come out of a conversation when some of these questions are asked. Okay, these are pictures that we've taken with consent. If you look closely, I don't think it's very clear, but if you look at the picture of the cake, it actually says advanced wedding anniversary. And so he's a patient and that's his wife. And we brought out a wedding anniversary cake for them because it was quite clear he was not going to make it till the wedding anniversary. So we brought it forward and it gave them a day of joy. Why I'm bringing this up now is because for some patients, dignity is maintained if something of their essence will survive beyond the event of their death itself. That is something that we call legacy. What will live on after I die? What part of me will survive my death? What will people remember me for? What will people think of when my name is mentioned? What am I leaving to my children? What experiences am I, memories am I giving them? So somebody's sense of dignity may very well be connected to what happens, how they're remembered after they're gone. And dignity therapy does talk about legacy building exercises, and it's a very, very important part of the work that we do in dignity therapy, and where we explore a person's life story. People close to the end of their lives like to believe that their lives meant something. And even if they didn't accomplish something massive, if they didn't win many awards, that the fact that they lived on this earth for X many years did mean something to somebody. And it's very important for us as humans to be witnessed by other human beings, to, that our life was not in vain. So we do legacy building exercises. How do people want to be remembered? And a lot of these have to do with their immediate families, of course. So patients are asked to speak into a tape about various aspects of life they would most want permanently recorded and ultimately remembered, things which they feel are most important and would most want their loved ones to remember. It could be an incident that happened when they were younger that they haven't spoken to anybody about, but which would explain certain aspects of their behavior. It could be an experience they had, um, when they were older. It could be maybe messages they want to pass on to their children when they're not going to be there. So on a milestone, on an 18th birthday, on the wedding day, when the first child is born, every time that a parent might have wanted to be around for a child. So you can actually leave messages. In today's day of technology, you don't have to write down letters and stuff. You can just take a video on your phone or whatever. So these are some of the legacy building exercises that go a long way in restoring somebody's sense of dignity. So some of the basic psychosocial interventions very quickly that we do are family meetings, very important. It helps reduce conflict, it clarifies information, it allows us to know what the dynamic is, and then to honor the strengths within the family and avoid further conflict. Supportive counseling, either to individuals or to to cognitive behavior therapy based communication. This is a very this very specific intervention, which is now, I think, expanded to include mindfulness integrated cognitive behavior therapy, which is an excellent tool. Facilitating psychoeducational support groups. This could be for spouses, for caregivers, for children. It could be for the patients themselves. Bereavement support and services, very, very important. Our relationship with the patient and the family does not end once the patient dies, but carries on for quite a while after. So there are follow-up phone calls, there are follow-up visits if possible, and people are invited to come and visit us once a month. So every month we have a bereavement support called Unarva in Pallium, and the attendance for that has been really, really good. And people come for years, and they really find solace in that. Recommendation for government schemes and other financial assistance, helping them navigate the system. What subsidies are available that can bring down their financial burden? And recently, we found out, that the Kerala state government actually, in a really beautiful gesture, uh, has said that there will be free electricity for people who have a life support device running in their home that requires electricity. We're not in 2012, but it's still in circulation. And I mean, that can really make a big difference to a family that has to keep an airbed running 24/7, to keep a person comfortable, and or if there's an oxygen concentrator or any of those machines required at home. So plus the caregiver pensions, there's other subsidies available. Linking with community resources that exist within the community, also mobilizing volunteers, and probably getting through to them through ASHA workers. There might be other groups that are operating in different areas, so to connect them with that. Sometimes if there is, women's issues, then we connect them to women's groups. Very often we provide legal aid, we facilitate legal aid when somebody requires it. And vocational training. Who gets vocational training from us? We have patients with spinal cord trauma. We have about 60 of them in our care, and we work with them for vocational training. We work with single mothers who, a lot of the times when a woman gives birth to a child with a congenital anomaly, the family abandons her. So she's stuck at home alone, looking after herself and her child, no means of earning a living. So she might be given vocational rehab. And of course, regular follow-ups, part and parcel of everything that we do. And definitely good documentation is important. So very quickly, some of the vocational rehabilitation work that we've done. This is someone who makes pens. We've provided stitching units, goats, umbrella making, whatever the person's interest and aptitude allows them to do, and which will earn them a living. We also provide support for children, both educational as well as emotional. Through our Kuti Kutam program, we provide educational support to children from disease-ravaged families, and of course, emotional support for bereaved children. That is something that Ashla um, runs. And parting words, I would say, is for us always to evaluate our interventions, just like you would evaluate medical interventions. It is very, very important for us to know whether the interventions we choose to apply are actually beneficial to the patient and family or not. And documentation, like I've said throughout, wherever possible, research validated techniques and not, just go in the decide to just have a conversation. And of course, like I said quite early in this presentation, there's an art and science and psychosocial care, just as in medicine. So I come to the end of my presentation. And Sri Devi, I'm going to leave you to take it forward.
Okay. I was speaking, no one heard me. Sorry. So thank you so much for the presentation. It is very elaborate and very informative. And I am sure that this, with just one presentation, we won't be able to understand the whole thing. But I think at least the essence has been passed very well. And I think we need more training and more uh, exposure to the situation, which makes us to work better in this field, because we are not trained to do all these things. So I think working in a team in Pallium India helped all of us to learn a lot from them. So I think as we see these situations, as we see people working like this, it will I know that the session will be really informative, but we need more training and more hands-on experience to understand how it works actually. Can we? Sorry, yeah.
No, I said absolutely.
Yeah. Can we move on to the case presentation, or should we take up just a few questions? We have 3 more minutes for case presentation. We can take up 1 or 2 questions from the participants.
Sure.
If anyone has some questions, you can unmute or you can type in the chat session before moving on to case presentation.
Am I audible?
Yes, sister, please.
Ma'am, if suppose the patient come to know that he or she is having advanced cancer and uncontrollable pain and fear or socioeconomic problem something, then they may have the thoughts of committing suicide. Then how will we handle it? How will we counsel them?
Okay, so suicide risk interventions as well as assessments are a science in themselves. But if I were to distill it down, I mean, I'm not suggesting for a moment that you go out and do exactly what I'm just saying. I would recommend a lot of research. But if you feel that somebody is at risk for suicide, there is actually, and I'd be happy to share it with anybody who wants it. There are ways to see whether how imminent the risk is, whether it is something that they're just thinking about, whether it's something that they're planning, whether this is something that they've already thought about, planned, and are ready to do it. So there are different things. There's something called parasuicide. There's something called suicide. So very often, if you feel that it's urgent, you need to ask the person, are you thinking of hurting yourself? Or have you had thoughts about ending your life? Now, very many of us are very scared to ask that question, because we feel that if by asking that question, we're putting that idea in their head. That's not true. That's not true. You ask the question, and the person, very often someone can see that they're suffering so much that they have, it's like asking a person if they have a heart condition doesn't give them a heart condition. So to say that they've never thought about suicide and I might be putting that idea in their head is not true at all. So if you genuinely feel that there's a risk for suicide, I would suggest sit the person down and ask them, I know you're going through a lot right now. Things must be really difficult for you. I'm just wondering, has this made you think, has this given you any self-destructive thoughts? And you can talk to me about it. If they say yes, Then there is a series of steps, that sequences that you need to go through in the risk assessment to, like I said, to understand how imminent the risk is. Have they made a plan? Okay, tell me more about your idea of suicide. If you were to do it, how would you do it? So but it gets a little bit more intense there, so you have to be prepared to ask those questions. But I'm very happy to send you literature on it, and at least by recognizing that this could be a real problem, you will be diminishing the intensity of that urge. So to ask the question very compassionately but directly, that would be the number one thing.
Okay, thank you, ma'am.
Thank you, Smriti. We all, when I heard this for the first time from you also, we were scared. If you ask what if they go and they got the idea, and what if they go and get suicide? And I still remember you teaching us how to do the primary assessment for suicide risk. And
I think,
yes, it gives them an opportunity to open up, I guess, rather than just doing it on their own.
And if you remember, Sridevi, we've had a couple of caregivers of patients who were suicidal, and we were able to, through this sort of process, talk them out of committing suicide. I mean, there was one mother of a child, and there was another lady, I remember very clearly, that this was when we first started doing the suicide risk, and I'm very pleased to say that those two people are alive and well today, where they very well may not have been.
And the importance of caregiver suicide risk assessment is also really, like, we might have missed that. We never thought they were thinking like that. We never had an idea that they might be thinking about suicide. But with this kind of assessment, it came out that they were in the risk of suicide. Thank you so much. Thank you, Sister Lily, for that question, which is really, really important.
Okay.
Yes, thank you for asking it.
Can we move on to the case presentation, Sister Rani Rose?
Case study. Okay, please read, ma'am. I will share the presentation.
Sister Rani Rose, are you ready for the case presentation? I can't see Sister Rani Rose because I can't see the full screen. Yes. Yes.
Yes, ma'am.
Okay, ma'am. Wait, ma'am.
Good afternoon, everybody. I am Sister Rani Rose from Loyola Healthcare Center in West Bengal, working in West Bengal. Next slide, please. My patient, she is 48 years old, and her diagnosis is metastatic adenocarcinoma liver with severe obstructive jaundice, post-operative status of cholecystectomy. Next slide, please. Her presenting complaints were she presented with mass per abdomen since 6 months, loss of appetite since 2 months, severe abdominal pain more in the right hypochondrium and epigastrium, and vomiting since 1 week. History of illness: 48 years old female who underwent cholecystectomy for calculus and polyp in the gallbladder, after which she was all right for 6 months and then started to get pain abdomen and jaundice. The histopathological report of the gallbladder is not with the patient, but the doctor who had operated her has explained to them that the polyp which was there in the gallbladder was cancerous and she will have to take the appropriate treatment for that. But because of financial constraints, they have not gone for any treatment after that. The mass per abdomen, what she noticed 6 months back, is increasing in size and is tender and hard now. An FNAC from the mass was done in the month of May 2019 at a higher center, and it shows metastatic adenocarcinoma poorly differentiated. On examination, her general condition was fair She was febrile, vitals were stable. She had pallor and icterus. There was no pedal edema or lymphadenopathy. Systemic examination, respiratory system, cardiovascular system was normal. Per abdomen, there was a scar of cholecystectomy is present. An irregular, hard, tender mass is felt in the epigastrium and right hypochondrium, and it is stuck to the scar and protruding out. No other organomegaly. Treatment and significant investigations. Her hemoglobin was 9 grams percentage and deranged LFT with total bilirubin 10.9, direct 8.1, and SGOT was 59, alkaline phosphatase was 377 unit per liter. Psychological aspects. She is a housewife from a very poor family. Her husband is a tea garden worker. She has 4 children, 1 son and 3 daughters. Eldest son is 25 years old and the youngest daughter is 19 years old. All are married and settled. Even though they are poor, she is well supported by the family psychologically, and they are not in a position to take her anywhere else for further investigations and treatment. She came to our center in June 2019 and got admitted twice for 1 week, after which she is coming regularly for the palliative care on OP basis, and the frequency of visit has increased now. Medications what were given when she was admitted, we treated her with IV fluids, injection, furos infusion for HB buildup, IV antibiotics, injection dexamethasone 4 milligram 12th hourly, injection tramadol 100 milligram 8th hourly, tablet Udiliv 150 milligram BD, Avil 25 milligram BD, and tablet Alprax 0.25 milligram at night. And now she is on tablet tramadol 100 milligram 6th hourly, tablet deflazacort 6 mg at night, and Estilo Plus at night, and rabiprazole D BD, and tablet Avil BD. Main concern: pain and the growing mass with increasing obstructive jaundice. Treatment plan for the future: patient does not know the diagnosis and the prognosis of the disease. Relatives have not yet believed it, communicated the bad news. Summary: 48 years old housewife with metastatic, poorly differentiated adenocarcinoma in the liver with probably primary in gallbladder, with post-cholecystectomy status 1 year, with mass per abdomen, infiltrating liver and the scar, and severe jaundice and pain. Discussion points: communicating the bad news to the patient, and is the palliative treatment she's now on satisfactory, or should we add some more drugs for her management? And also, now on the basis of this class, making an echo map, and again some more information about her family and genogram and all. Thank you.
Thank you, Sister Rani Rose, for your presentation. I think for today's discussion, we would focus more on communicating the bad news and how to deal with the reactions, probable reactions or emotions once you communicate the bad news to the patient. And regarding the palliative treatment and drugs, I think we'll talk about it later. And Sister Rani, I'm so glad that Smriti communicated well about the importance of including the community participation and the support system, including the family and the eco map concept and the dignity. So it is communicated well. Thank you so much. Over to you, Smriti.
Okay, thanks, Shri, and thank you, Sister Rani. Thank you for that presentation. Okay, so communicating bad news to the patient. I think we can stop the screen share now so that we can have everybody else also visible. So,
Vishnu, we can stop the screen sharing.
Yeah, thank you, Vishnu. Okay, so this is always, I think, one of the first problems that we all face is having a family that is, there's collusion going on. Sister Rani, has there been any conversation with any of the family members as to why the prognosis and diagnosis, okay, forget the prognosis, but the diagnosis has not really been communicated? That's question number one. And I have one more question. She's obviously been going through this for a while now. I mean, it's been over a year. What I would probably ask her is what she thinks of her, what her understanding is of what she is going through. So has that sort of been elicited from her at all? Has anyone spoken to her about what her understanding of her illness is? And has anyone in the family been spoken to as to why she is not aware of the diagnosis?
Yes, ma'am. Actually, whenever the patient comes to the hospital, her husband was accompanying her. So when we admitted her, I called personally the husband and asked about the details, and I asked him whether she knew about the disease. Then he said no, and at present we do not want to communicate that. Then I asked why, but she came in severe pain. Then that time he said she is suffering from pain. Let her pain comes down. After that we will tell. And actually the patient husband also was not sure that it was a cancer. After coming here only we told them, because reports no, the doctor had told, and the prognosis, about the prognosis we had to explain. So when the pain was less and the patient was about to discharge, that time again I asked the patient's husband. He said not now, after some time. So like that it was delayed, and the patient knows only that she has pain on that operative site. Other than that, she does not know anything, and she has jaundice. More than that, she does not know about the disease.
And she doesn't know why the surgery was required?
That she said there was a stone for that only. Usually gallbladder stone, that surgery is done. So that much only she knows.
You mentioned in your presentation that even though they are poor, they are well supported psychologically by the rest of the family. So if I could just help, if you could help me understand, they're all married and the youngest is 19.
Yes.
So obviously they've also been married very young. But do they all live nearby? Do they get to visit her, or are they?
Yes, they all are nearby. The son is nearby, and the daughters also not very far. They come to see her at home. Here in the hospital, no, many did not come. Only son had come. Otherwise, they regularly visit her, she said.
Okay. So one thing I would probably explore is the relationship between the husband and the wife. Again, she's quite young. She's 48. They've been married young. They've had children very young. Children have settled, which must be a relief to the family. Once all the children are married and they've left the family, that a couple goes back to living alone. Their dynamic, their relationship is worth exploring, because as long as you have a house full of children and all of that happening, the children take up a lot of the attention and stuff. But now that you've said that all children are married and have left, there's something which we call the empty nest syndrome also, where two people are left together. I would actually look into what their relationship is like now and what their relationship was like before. I find quite often that caregivers sort of stand guard like that. saying no. They are the gatekeepers, and they will decide what information reaches the patient when and at what pace. And very often the gatekeeping has a fear component attached. So it's a fear that the caregiver has that they project onto the patient. So very often, and I've been a caregiver myself, and I can tell you that I didn't want my mother to know because I was scared of what the fallout would be. So I would say, no, 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 but we make assumptions. Now, here is a woman who's raised 4 children, sent them off, seems to be like, has lived quite a packed life in just 48 years. And I wonder what the dynamic between the two of them is. I would actually, before trying to break the news to her in any way, obviously it'll need the consent of her husband, I would try and explore what his fears are. To me, that would be step one. And maybe not, I know it's very busy in an outpatient unit, so it's not easy to have these very intensely emotional private conversations. But if he could come on a day when it was just him alone, and you could have, and with her not around, maybe you could have a conversation with him and find out what he feels about her prognosis. What she feels something is, I mean, that's one thing, but what does he feel, right? And what are his fears? If they have a really good relationship, he must be also really afraid to face up to the fact that she's dying. So by getting, sometimes breaking the news to the patient means that the whole family can't hide from it anymore. Everybody has to acknowledge it. But as long as the patient is not told, then the whole family can keep up the charade. So if I were to break it down into goals, I would say I'd try and have a conversation with him first and try and understand what his specific fears are, try and work through those fears, understand how important it might be. Is there unfinished business that she might want? Is there somewhere that you would like to, are the people that you would have liked to call, and this and that? So elicit their story from him. And by, I think, having that conversation, you will also gain his trust and build rapport. And maybe then he will trust you to tell her in the right way. So it's a step-by-step process to me.
Yes, ma'am. We will do that. Thank you.
Thank you. And I'm glad you found the EcoMap useful. We find it very, very useful. And I think it goes a long way. So if you draw that EcoMap and you find who their support systems are within their community, is there her own sibling that she's close to, if there's a group of women that she's close to or whatever, that will also give you some help, I think, in looking after them.
Yes, sure, ma'am.
Thank you so much, Smriti. I would like to add a few more points into that, which I heard from you years back. So one thing is that sometimes it's okay not to break the bad news. There are examples that we faced together where it was not mandatory to break the collusion most of the times, and because we always have the enthusiasm to communicate the bad news the moment we start learning it. That is one thing. And second thing, when you explore the fear of the family member, most often they'll be scared that if you tell the bad news, they will not be able to cope, or the BP may shoot up, so they may get into a shock. And I still remember one son who was very reluctant to tell the diagnosis to the father, and when Smriti was asking, what are you scared about him, he was telling, my father's BP will shoot up and he may die on the spot. So she wanted the medical people to pitch in and tell him that we are not expecting such kind of adverse effects when you tell a bad news. And so it was really an interdisciplinary teamwork to make him understand that. So it's very important to ask why the caregiver wants to hide the news. It's exactly the gatekeeping, but there must be some element that they are scared about. It's usually something which is easily solvable, easily answerable, like a shoot up in the BP or suicide. They may be scared that she will stop taking treatment, she may suicide, or she will lose the courage to fight the cancer. So these are the things which they come up very often. Anything else to add on to that, Smriti?
Oh, thanks, Sridevi. That was thank you for bringing up those 2 points. I'm always, it becomes a bit of a, I think, a touchy topic when we say, why is it important to break bad news? We in palliative care sometimes, like Sri Devi said, we feel obliged that once we've learned this, how to break bad news, we have to do it with every patient, with every family we meet. But sometimes it's not necessary. Sometimes if the person has time, we don't have to do it immediately now. It might happen over a period of a few weeks or a few months. Once, like I said, rapport is built, trust is gained. And in some cases, it's not needed at all. It's not necessary. What do we end up doing by telling somebody that death is impending? So is it just that, okay, we've done our duty, or is there actually something that person can gain out of that knowledge? Now, if somebody would like, acknowledges the fact that there is limited time, then they might say, hey, I want to meet this relative, I want to do this, I want to get my finances in order, I need to tell you that these debts are there, that these loans are there, whatever else, right? I want to make sure my will is done. There might be people like that, and that really benefits them. But if it is somebody whose symptoms are controlled, has very few days to live, is in and out of consciousness, is it necessary that we tell that person that, is it necessary for us to break bad news to that person? So that is something I'm really glad, Shri, that you brought up. That's something for all of us to think about. And like you said, the fear could be something that is addressable. And of course, what is required of us is, if we are going to ask that question, we have to make sure that we create the time and space to answer it well. So do not ask that question if you are not prepared to take some time out to actually address it with the family. It would be a disservice to ask what that fear is and then not do something about it. So that's the only other thing that I would add, to make sure you have the space to have that conversation.
Yes, ma'am.
Any other questions from the participants? I think if we would have compiled many questions in the past few presentations, we would have had enough discussion. There were always questions regarding psychosocial issues or the communication, at least one question in each presentation. Especially, I think there was a very difficult question regarding communicating the husband's death to the patient. I think Smriti was most wanted during that session. Yeah. So any other question that participants want to ask?
Yes, ma'am. I want to ask you, tell you something. When you talked about the ABCD of dignity, you were saying, no,
Yes.
I had a patient who was diagnosed as cancer, and it was communicated to her. After that, many people used to come and visit her, and all the time they say poor thing, or they just show their pity, which she was so much annoyed with that. So I think the dignity of you were saying about the dignity of the person, no? So what would we could have done in that case? That's my question. She was not annoyed with everybody's sympathy or compassion, what they're saying.
Well, sounds like your patient was somebody who was, see, actually, none of us like to be pitied, no? We like people to be compassionate. We don't like people to come and feel sorry for us. And I think having a conversation with, having an open conversation with the immediate family would have been something that was useful, because as a healthcare team, we can't sort of have this conversation with every visitor who comes. But obviously the people who are visiting are people who are close to the family in some way or form. Having a family meeting, talking about dignity, psycho-educating somebody about dignity. I mean, like I said, dignity and love and joy, and like we all have these words floating around somewhere in space, but these are real things. So if we sit down and educate the family about, see, this is what is upsetting her. Now, you know who's coming to visit. You have a relationship with these people. How can we prevent them from, maybe there are certain sentences that we need to stay away from. Maybe you can even list out those sentences that upset her. There are some sentences that are triggers to people, oh God, so sad, bichara, all these things. So to actually list out those things, take the family through it, get them to then become the people who communicate to the visitors. I mean, that's something that possibly could be done. If it's verbal interactions that have caused offense to her dignity, people coming and saying certain things to her. I would also look out for non-verbal cues. Were there things that she didn't like people doing for her? And have a conversation with her. Of course, not just with the family. Have a conversation with her. Ask her, those dignity-related questions. When did you feel that your dignity was taken away from you? And get it from the person's mouth. And that would really inform the kind of communication that I would either encourage or discourage amongst people coming to visit the patient.
Thank you so much, Smriti. And thank you so much, Sister Rani Rose, for the presentation. I know that there was another medical question regarding the drugs. I would certainly address them when I send the feedback. I can add few notes in the presentation to that question. And thank you everyone for active participation. And any other doubts, you can always write to Rajalakshmi, and we will forward your queries to Smriti and get your answers back.
I'll happily answer any questions anyone has. Thank you all very much.
Thank you, Smriti, for your time.
Thank you. Thank you, Shri. Thanks
Thank
a lot.
you.
So everyone, please send your feedback before logging out.